This portion of CardioSource Video News is supported by the makers of Xarelto.
I'm Peter Block for CardioSource Video News here in Chicago at ACC 2012. With me is Dr. Harold Litt. Harold has just presented the Acrin trial. Now, Harold, tell me what that is.
The Acrin Pa 4005 trial was looking at the use of coronary CT for evaluation of low to intermediate risk patients who come to emergency departments with chest pain. Our primary hypothesis was a safety goal. We were trying to prove that patients who had a negative coronary CT could be safely discharged from the emergency department and have a less than 1% 30-day event rate.
So that's what you were trying to prove. So obviously, you must have chosen relatively low-risk patients to do this trial for. Is that correct?
Yes, these are low to intermediate risk patients with TIMI scores of 0 to 2. Patients who had previous history of heart disease or others who are at high risk wouldn't be appropriate for this study.
Okay, so the study did what? Sent them to CT and sent them to standard therapy, to diagnostic therapy, or how'd you do it?
Yeah, we randomized patients in a 2-to-1 fashion. Twice as many patients were randomized to coronary CT as to traditional care. And then we followed those patients to see what diagnostic tests they had, what were the results, things like length of stay in the emergency department, how many patients were discharged directly from the ER, and also resource utilization out to 30 days.
I actually listened to you present this trial, and I was impressed that the length of stay in the emergency room was significantly diminished in patients that had CTs. Tell me what some of the other results were.
Well, as you said, in addition to demonstrating a 25% decrease in length of stay in patients in the CT arm and a 50% decrease in length of stay for those who had negative studies compared to traditional care, we also were able to show that twice as many patients were discharged directly from the emergency department in the CT arm as in the traditional care arm, and that the use of other resources such as cardiac catheterization were similar. In fact, concerning cardiac catheterization, patients in the CT arm who went on to cath had a much higher rate of positive caths than patients in the traditional care arm.
Well, that's a good thing, isn't it? So you actually selected out. So as a doc, I always think to myself, you know, if I send a patient out, even a low-risk patient, I'm always worried that they're going to drop out there as soon as they walk out the door. What percentage of your patients actually had bad outcomes, and at what length of time?
Well, we know that when patients are discharged from emergency departments using traditional rule-out algorithms, that 2 to 3% of them will actually end up have had a heart attack. Looking at our study in the CT arm, those patients who had a negative CT, 0 out of the 640 patients ended up having a heart attack or cardiac-related death at 30 days. So we did meet our less than 1% safety outcome.
So certainly you've shown that CT is safe, seems to work, decreases ER time, and increases positive cath time. Sounds like it was a pretty good trial.
It was. Of course, there are some concerns. CT is a study that uses radiation, and however, that amount of radiation used for coronary CT is generally less than that for nuclear medicine SPECT myocardial perfusion imaging, and it's similar to that used for cardiac cath. One interesting finding was that in the CT arm, we identified 3 times as many patients with coronary disease as in the standard traditional care arm. So the question is, what happens to those patients? And we're going to be following everybody out to 1 year to see whether they will get better primary prevention, which will keep them from coming into the ER with their first heart attack, or whether they'll just get additional testing, which won't really improve their health.
Still more to learn from this trial. Thank you, Dr. Litt.
Thank you very much.